What's up, everyone? It's Miles here from bootcamp.com, and today in pulmonology, we're going to be going over pulmonary hypertension. So, just as an overview, pulmonary hypertension just refers to high blood pressure in the pulmonary circulation. And depending on where the origin of the high blood pressure is, we can classify it as pulmonary venous hypertension or pulmonary arterial hypertension. So, if we just take a look at this diagram over here, we know that blood is pumped from the right ventricle through the pulmonary arteries into the pulmonary capillaries, and then into the pulmonary veins, and then returned to the left side of the heart. Now, in the case of pulmonary venous hypertension, the underlying problem usually involves the left side of the heart, and as a result, blood is going to back up into the pulmonary veins, then into the pulmonary capillaries, and then into the pulmonary arteries, and finally into the right side of the heart. So in this case, there's first high blood pressure in the pulmonary veins, which then backs up into the pulmonary arteries. Now, in the case of pulmonary arterial hypertension, the high blood pressure mainly just involves the pulmonary arteries, which then backs up into the right side of the heart and mainly leaves the pulmonary veins unaffected. So with that overview in mind, let's start off with pulmonary venous hypertension. So like we mentioned, in pulmonary venous hypertension, we're going to see high blood pressure not only in the pulmonary veins, but in the pulmonary arteries as well, because blood is backing up from the pulmonary veins into the pulmonary arteries. And like we mentioned, the most common cause of pulmonary venous hypertension is going to be problems with the left side of the heart. So first, we can have left heart failure. In the case of left heart failure, the left ventricle won't be able to pump blood into the arterial system very well, and so it's then going to back up into the pulmonary veins and then into the pulmonary arteries and the right side of the heart. And furthermore, pulmonary venous hypertension could be caused by valvular diseases on the left side of the heart. So first, we'll talk about mitral stenosis. So again, just looking at this diagram over here, we know that the mitral valve is between the left atrium and the left ventricle. And if this valve becomes stenotic, then of course blood won't be able to pass from the left atrium into the left ventricle very well, and as a result is going to back up into the veins, the pulmonary arteries, and the right side of the heart. Furthermore, we can also see this in mitral valve regurgitation. Again, just looking at this diagram over here, we have the mitral valve between the left atrium and the left ventricle. And if it's too wide or insufficient, then when the left atrium pumps blood into the arterial system, some blood is also going to go into the left atrium. And so the left atrial pressures will become high, and then blood will again start to back up into the pulmonary veins, pulmonary arteries, and right side of the heart. So the commonality between left heart failure, mitral stenosis, and mitral valve regurgitation is that we're going to see high left atrial pressures in all three, and that's going to cause blood to back up and raise pressure in the pulmonary vasculature. Now, taking a look at this diagram again, one important location that you want to keep in mind is right here in the pulmonary arteries before the pulmonary capillaries. It's around this point where the pulmonary arterial hypertension originates, and so the blood pressure is going to build up behind this point and not involve the pulmonary capillaries. Whereas in the case of pulmonary venous hypertension, the problem mainly arises in the left side of the heart, and so it's going to involve the pulmonary veins, the pulmonary capillaries, and the pulmonary arteries. And so as a result, it does involve the pulmonary capillaries. And so an important feature of pulmonary venous hypertension is that the blood pressure is going to become high in the pulmonary capillaries. And as a result of high hydrostatic pressure, we're going to see fluid leaking out of the pulmonary capillaries and cause pulmonary edema. So this is kind of a hallmark feature of pulmonary venous hypertension, is that we're going to see pulmonary edema, and as a result, this is going to cause dyspnea. Okay, so now let's get into pulmonary arterial hypertension. So like we mentioned, in pulmonary arterial hypertension, there's going to be high blood pressure, usually over 20 millimeters of mercury, that originates in the pulmonary arteries. So in terms of this diagram, the blood pressure is going to be high in the pulmonary arteries and get transmitted to the right side of the heart, but it's not going to involve the pulmonary capillaries or the pulmonary veins. Now, pulmonary arterial hypertension can be subdivided into primary pulmonary arterial hypertension, which is a problem with the pulmonary artery itself, or it can be classified as secondary when there's an underlying condition that's just causing vasoconstriction of the pulmonary artery. So first, let's start off by talking about primary pulmonary arterial hypertension. And in terms of the pathogenesis, there's kind of two parts of the pathogenesis that you want to keep in mind. The The first part is that there's going to be an intrinsic vascular change in the pulmonary artery and arterioles. And this vascular change process that's occurring is called arteriolosclerosis. And what's really happening here is that the smooth muscle in the vasculature is undergoing hypertrophy and hyperplasia. And furthermore, in the intima, we're going to see this kind of onion skin thickening and fibrosis. So just taking a look at this diagram here, we can see here is a normal vessel with the normal layer of smooth muscle. And after the process of arteriolosclerosis, we can see that that smooth muscle layer has thickened due to hypertrophy and hyperplasia. And furthermore, we also see some fibrosis in the intima. And so now we have effectively narrowed the lumen of these vessels. And so the right side of the heart has to pump blood through a narrowed lumen. And as a result, the blood pressure inside of these vessels is going to increase. So that's kind of the first part of the pathogenesis. And the second part of the pathogenesis is there's going to be an imbalance of mediators, mainly an increase in endothelin and a decrease of nitrous oxide. Now, endothelin is a vasoconstrictor, and the way that I remember this is that the inside of a blood vessel is lined with endothelium, and so endothelin is making the endothelium go in, or vasoconstricting. And of course, nitrous oxide is a vasodilator. So if we have an increase of a vasoconstrictor and we have a decrease of a vasodilator, the end result is that we're going to see vasoconstriction. Now, what causes these vascular changes plus this imbalance in these vasomediators? Well, the first is idiopathic, which means that the etiology is not completely understood, but classically it arises in a young adult female, usually young 30s or so, and they may or may not have this mutation called a bumper 2 mutation. Bumper 2, or BMPR2, which stands for bone morphogenetic protein receptor, when active, it usually keeps smooth muscle cell proliferation in check, especially in the pulmonary vasculature. However, when this gene is mutated, now smooth muscle cell proliferation, especially in the pulmonary vasculature, starts to go unchecked and it proliferates a little bit too much. And as a result, we can start to see that arteriolosclerotic change that occurs in primary pulmonary arterial hypertension. And because the bumper 2 mutation is a hereditary genetic defect, sometimes we classify this as the familial form. And so sometimes in question stems, they'll give you that the patient has a family history of pulmonary arterial hypertension. Now, another cause of primary pulmonary arterial hypertension is connective tissue diseases. And one that you really want to keep in the back of your mind is scleroderma, specifically the limited form of scleroderma. And the way that I like to remember this is that the limited form of scleroderma is just limited to the vessels, whereas the diffuse form of scleroderma is more diffuse across the lungs and results in an interstitial lung disease. Now, in the limited form of scleroderma, what we're going to see is T-cell inflammation, fibroblasts laying down connective tissue, and we're also going to see an increase in endothelin. And these three things together contribute to the pathogenesis of primary pulmonary arterial hypertension in limited form scleroderma. Now, in terms of presentation, when we talk about secondary pulmonary arterial hypertension, this is due to an underlying condition, so they're going to have a broader presentation. But in terms of primary pulmonary arterial hypertension, the main presentation that you want to think about is dyspnea on mild exertion. So the way that you want to be thinking about this, especially for this idiopathic form here in terms of board style questions, is you're going to get a young adult female, usually in her early 30s, and now all of a sudden she's having dyspnea or trouble breathing when she's doing things like ordinary chores or walking around the block. And furthermore, she has a family history. Maybe her mother experienced similar symptoms when she was at that age. And then they're going to ask you, what's occurring in the pulmonary vasculature? And so now you're going to start to think about things like smooth muscle hypertrophy or hyperplasia, or intimal fibrosis, Or they might ask you about what's occurring with the vasomediators, in which case, then you would start saying increased endothelin and decreased nitrous oxide. Okay, so now let's talk a little bit about the secondary pulmonary arterial hypertension. And this is going to usually be due to hypoxemia, which recall is going to result in hypoxic pulmonary vasoconstriction. And two very common conditions that you want to keep in mind that we see this are things like chronic obstructive pulmonary disease and obesity hypoventilation syndrome, where we're really just not ventilating those alveoli very well, and so the partial pressure of oxygen starts to drop in the alveoli. So if we just draw in our alveoli here, if the partial pressure of oxygen within this alveoli is low, this is going to result in vasoconstriction of these arterioles and the pulmonary artery here, and this is going to result in secondary pulmonary arterial hypertension. So one concept that you really want to make sure that you understand is that when we have high vascular resistance in the pulmonary circulation, whether it's due to primary or secondary pulmonary arterial hypertension, this is going to cause pressure to back up into the right side of the heart, and it's going to cause right heart stress. When we have that right heart stress, this is going to lead to right heart enlargement and dysfunction with eventual heart failure. And so we can start to see things like elevated jugular venous pressure or hepatomegaly or things like peripheral edema. So like we mentioned, in pulmonary arterial hypertension, the problem is arising in the pulmonary arteries and the pressure is backing up into the right side of the heart. So first of all, because the problem is arising before the pulmonary capillaries, we're not going to see any involvement of the pulmonary capillaries. So things like pulmonary capillary wedge pressure, which is going to be elevated in pulmonary venous hypertension, is actually going to be normal in pulmonary arterial hypertension. And like we saw pulmonary edema in pulmonary venous hypertension, in pulmonary arterial hypertension, there's going to be no pulmonary edema. And because there's going to be no pulmonary edema, we're not going to hear things like crackles. And so these two things right here are kind of useful when trying to differentiate between pulmonary venous hypertension versus pulmonary arterial hypertension. And second of all, in terms of diagnosing this condition, looking at cross sections of the pulmonary arteries and arterioles is a little too invasive and dangerous and mostly only reserved for autopsies. So in terms of boards questions, the hints that they're going to give you are actually going to be diagnostics relating to the right-sided heart stress. Okay, so with that in mind, now let's talk about the diagnosis. So the first thing that you just kind of have to commit to memory is these plexiform lesions that are found in the vessels in the idiopathic form of pulmonary arterial hypertension. So just taking a look at this histology image here, we see this round structure here. This is the pulmonary arteriole, and then kind of perpendicular to this, we have this complex vascular channel that has formed. We can see kind of the lumen right here, and there's a lumen right here. These are called plexiform lesions that form in the idiopathic form of pulmonary arterial hypertension. So next, a classic finding is a loud P2, and this makes sense because there's going to be high pressure in the pulmonary arteries, and so as a result, when the pulmonary valve closes, it's going to close with very high force. Just taking a look at this diagram here, the pulmonary valve is located between the right ventricle and the pulmonary artery. And if there's really high pressure in the pulmonary artery, then when the right ventricle pumps blood during systole, afterwards, that high pressure is going to be transmitted backwards and close this valve with really high force. And that high force closure is going to be heard as a loud P2. Now, another finding that we may or may not see is a functional tricuspid regurgitation. So again, we're going to have high pressures in the pulmonary artery. This is going to back up into the right side of the heart and can actually enlarge the right side of the heart. Let's just recall that the tricuspid valve is located between the right atrium and the right ventricle. And if the right side of the heart enlarges, this can actually pull the tricuspid valves apart such that now there's a functional tricuspid valve regurgitation. So when the right ventricle pumps blood, some will go into the pulmonary artery, but some will also travel in a retrograde fashion from the right ventricle back into the right atrium. And of course, a tricuspid valve regurgitation is heard as a hollow systolic murmur, heard best at the left lower sternal border. So 3 other diagnostic findings here that you can kind of just clump together as right heart stress is if we do a right-sided catheterization, we'd be able to see high pressures in the right ventricle. If we do a transthoracic echocardiogram, we'll be able to see right ventricular hypertrophy. And if we do an ECG, we'd be able to see right axis deviation, which in this case just kind of indicates that there is right ventricular hypertrophy or overload. Finally, like we mentioned, because the problem is arising in the pulmonary arteries before the pulmonary capillaries, we're not going to see involvement of the pulmonary capillaries. And so we're going to have normal capillary wedge pressure, and there's going to be no pulmonary edema. Okay, so finally, let's talk about the management. So in terms of management, if you understand the imbalance in these vasomediators here, then the medication really makes sense. So the first medication here is bosentan, which blocks endothelin, and so that's going to result in decreased vasoconstriction. And I like to take the EN here in bosentan to remind me that it blocks endothelin. And finally, remember that not only is there an increase in endothelin that we can block with bosentan, but there's also a decrease in nitrous oxide, and so we can supplement with things like prostacyclin or sildenafil, which are vasodilators. All right, and that's all we got for our video on pulmonary hypertension.